Today let's see about disease of lacrimal apparatus. The lacrimal apparatus comprises of lacrimal glands, lacrimal passages which include puncta canaliculi, canaliculi and nasolacrimal duct, lower canalicus, valve fastener, lacrimal sac, lacrimal ducts, lacrimal gland. Lacrimal gland include main and accessory. Main lacrimal gland, it consists of upper orbital and lower pulpal part. Orbital part is larger, about the size and shape of a small almond, and is situated in the fossa for lacrimal gland at the outer part of orbital plate of frontal bone. It has got two surfaces, superior and inferior. Superior surface is convex and lies in contact with the bone, and inferior surface is concave, lies in levator pulpably, superioris muscle. Palpebral part. Palpebral is small and consists of only one or two lobes. It is situated upon the course of ducts of orbital part, from which it is separated by LPS muscle. Ducts of lacrimal, about 10 to 12 ducts pass downwards from main gland to open in the lateral part of superior pharynx. One or two ducts also open in the lateral part of inferior pharynx. Accessory lacrimal glands of Crossi, glands of Wolfing. These are microscopic glands lying beneath the palpebral conjunctival tissue, and glands of Wolfing. These are present near the upper part of superior dorsal plate. Structure: blood supply and nerve supply. Structure: all lacrimal glands are serous acini, similar in structure to salivary glands. Microscopically, these consist of glandular tissue, connective tissue and puncta. Blood supply: major blood supply is ophthalmic artery. Nerve supply: sensory supply comes from lacrimal nerve, and sympathetic supply from the carotid plexus. Secretory motor fibers are derived from superior salivary nucleus of pons. Greater petrosal nerve, synapse at pterygopalatine ganglion, zygomatic nerve, lacrimal nerve and lacrimal gland. Lacrimal passages. Lacrimal puncta. These are two small rounded or oval openings on upper and lower lids, about 6 to 6.5 mm. Respectively temporal to inner canthus. Each punctum is situated upon a slight elevation called lacrimal papilla, which become prominent in old age. Normally the puncta dip into lacus lacrimalis. Lacrimal canaliculi. Lacrimal canaliculi, superior and inferior canaliculi join the puncta to lacrimal sac. Each canalicle has two parts, vertical and horizontal part, which lie at right angle to each other. Horizontal part converges towards inner canthus to open in the sac, and two canaliculi may open separately or may join to form common canaliculi, which opens immediately into outer wall of lacrimal sac. A fold of mucosa at this point forms the valve of Rosa and Muller, which prevents reflux of tears. Lacrimal sac location lies in the lacrimal fossa, located in the anterior part of medial orbital wall. Lacrimal fossa is formed by lacrimal bone and frontal fossa maxilla. It is bound by anterior and posterior lacrimal crest. Lacrimal fascia, which encloses the lacrimal sac, is formed by periorbita. Periorbita splits at the posterior lacrimal crest into two layers, which enclose the sac and again fuse at the anterior lacrimal crest. Between the lacrimal sac and the fascia lies alveolar tissue and venous plexus, which becomes continuous around the nasolacrimal duct. Size: when distended, lacrimal sac is about 12 to 15 mm in length, 5 to 6 mm breadth, with a volume of about 2 cc. Parts: it has got three parts: fundus, body and neck. NLD, nasolacrimal duct, it extends from neck of the lacrimal sac to inferior meatus of the nose, neck to nose, neck of the lacrimal sac to nose. It is about 15 to 18 mm long. Direction of NLD is to downwards, backwards and laterally. Externally, its location is represented at a line joining inner canthus to ala of nose. The upper end of NLD is narrowest part. Tear film structure. It is detailed structure of fluid covering the cornea, called it precorneal film. It is consists of three layers. Mucous layer, it is the innermost and about 0.2 micrometer with thick stratum of tear film. It consists of mucin secreted by conjunctival goblet cells, and glands of Mons. It converts hydrophobic corneal surface into hydrophilic one. Aqueous layer, the bulk of tear film is formed by this intermediate layer, which consists of tears secreted by main and accessory lacrimal glands. The tears mainly comprise of water, small quantity of solutes, sodium chloride, sodium, sugar, urea. Therefore, it is alkaline and salty in taste. Lipid or oily. This is the outermost and thinnest layer of tear film formed at air-tear interface, from which the secretion of meibomian jays and mole glands. This layer prevents the outflow of tears, retards the evaporation, lubricates eyelids as they slide over the surface of globe. Structure of tear film: lipid layer, then aqueous layer, then mucous layer, then below the mucous membrane glycoprotein with microvilli. Lipid layer corresponds to meibomian gland, lacrimal gland corresponds to aqueous layer, then goblet cells secretes the mucous layer. Function of tear: keeps moist, provides oxygen, washes away debris, prevents infection, facilitates movement. Secretion of tears: tears are continuously there are two types of tears: basal tear and reflex tears. Basal secretion, reflex secretion is known as basal tears and reflex tears. Reflex secretion responds to sensation from cornea and conjunctiva, probably produced by evaporation, breakup of tear film. Hyperlacrimation occurs due to irritative sensation from cornea and conjunctiva. Often pathway of the secretion is formed by fifth nerve and efferent by parasympathetic secretory mode supply or lacrimal gland. Elimination of tears by lacrimal pump mechanism. From lacrimal gland, the tears flow downwards and laterally. Across the ocular surface. A variable amount of tears is lost by evaporation from the ocular surface. The remainder of tears flow along the superior and inferior margin steps and collects as lacus lacrimals in the inner canthus, from where it is drained by lacrimal passage into nasal cavity. About 70% tears is drained via inferior canaliculus and 30% via superior canaliculus via active lacrimal pump. 70% by inferior and 30% by superior. When eyelids close with each wing, contraction of pretarsal orbicular circuli which compress the ampulla and shortens the canaliculi. This movement propels the tear fluid present in the ampulla and horizontal part of canaliculi towards the lacrimal sac. Contraction of preseptal fibers of orbicularis distend the lacrimal sac and creates therein negative pressure which draws the tear fluid from canaliculi into lacrimal sac. Relaxation of pretarsal orbiculis allows the canaliculi and ampulla to expand and reopen and to draw the tear fluid from lacus lacrimal into marginal tear strips. Relaxation of preseptal hornal muscle results in collapse of sock as a consequence of positive pressure is created which forces the tears down to NLD into nose. Gravity also helps in downward flow. Dry eye is not a disease entity but symptom complex occurring as a sequel to deficiency or abnormality. Etiology: aqueous deficiency, dry eye, known as keratoconjunctivitis, sicca. Aqueous deficiency, dry eye. Sjogren syndrome, primary keratoconjunctivitis, sicca. Non-Sjogren syndrome, sicca. It may be grouped as primary age-related hyposecretion. It is the most common cause. Lacrimal gland deficiency as seen in congenital alacrimia, infiltration of lacrimal gland, in sarcoidosis, tumors, post-radiation fibers, etc. Lacrimal gland duct obstruction is seen in old trachoma, chemical burns, cicatricial pemphigoid, Steven-Johnson. Reflex hyposecretion as seen in familial dysautonomia, Parkinson disease, reflex sensory black, reflex motor brain, 7th cranial nerve damage. Evaporation dry eye. It is caused by condition which decrease tear film stability and thus increase evaporation. Causes can be grouped as meibomian gland dysfunction as in chronic posterior blepharitis, rosacea, congenital absence of meibomian glands. Lack of ophthalmos as seen in facial nerve palsy, severe proptosis, symplectron and eyelid scarring. Defective blinking such as low blinking rate as seen in prolonged computer uses and other causes. Vitamin D deficiency, other factors affecting ocular surface, example topical drugs, preservatives, contact lens wear, ocular surface allergic disease and scarring disorders. Clinical features: signs, symptoms: dry eye including irritation, foreign body sensation, feeling of dryness, itching, non-specific ocular discomfort, chronic sore eyes, not responding to variety of instilled drops earlier. Then signs: tear film signs may be present as stingy mucus, particular matter, marginal tear strip is reduced or absent, normally it is 1 mm. Froth in tears along the lid margin is sign of meibomian gland dysfunction. Froth. Conjunctive sign: it becomes lusterless, mild congested, conjunctival xerosis, keratinization may occur. Rose Bengal or lissamine green staining may be positive. Corneal sign may be so punctate epithelial erosions, filaments, mucus flakes. Corneal may lose luster. Vital signs: fluorescent rose Bengal, Lissaman green may delineate the above lesions. Signs of causative disease: such as posterior blepharitis, congenital scarring, Steven Johnson, etc. Tear film tests. Tear film breakup test (BUT). It is the interval between a complete blink and appearance of first randomly distributed dry spot on the cornea. It is noted after installing a drop of fluorescein and examining in cobalt blue light of slit lamp, but is VUET is an indicator of adequate mucin component of tears. It normally values ranges from 15 to 35 seconds. Value less than 10 seconds imply an unstable tear film. Skrimer test: it measures total tear secretions. It is performed with the help of 5 into 35 mm strip of Wattman 41 filter paper. Patient asked to kept in lower fornix at the junction of lateral 1/3 and medial 2/3. Patient asked to look up and not blink or close the eyes. Skrimer test: lower fornix, kept in the lower fornix. After 5 minutes, wetting of the filter paper strip from the bend is measured. Normal value of Skrimer test is more than 15 mm. Values of 5 to 10 mm are suggestive of moderate to mild keratoconjunctivitis (SICA), and less than 5 mm is severe keratoconjunctivitis (SICA). Rose Bengal staining: it is a very useful staining for detecting even mild case of cases. Depending upon the severity of cases, 3 staining patterns A, B, C, and have been described. C pattern represents mild or early case with fine punctate stains in the interpalpebral area. B, moderate case with extensive staining. A, severe case with confined staining of conjunctival cornea. Grading of dry eye: level 1 mild dry eye, level 2 moderate, level 3 severe, level 4 very severe. Treatment: supplements are tear substrate, methylcellulose, hydroxymethylcellulose, hypromellose are given. 0.7% methylcellulose given, 0.25 to 0.7% given, 0.3% hypromellose, 1.4% polyvinyl alcohol. Topical cyclosporin is reported to be very effective drug for dry eye in many recent studies. Mucolytics: 5% acetylcysteine used 4 times a day. Helps in disposing mucous threads and decreasing tear viscosity. Preservation of existing neem by reducing evaporation. Decreasing room temperature. Use of moist chambers. Protective glass. Punctate occlusion to decrease drainage can be carried out by collagen implants. Crinoacrylate tissue adhesives, etc. Electrocauterization. Permanent lateral tersography may be required in severe cases. Treatment of causative disease: Sjogren syndrome. Treatment of causative disease: vitamin A supplement. Treat the cause of lack of ophthalmos. Systemic tetracycline. Sjogren syndrome: it is an autoimmune chronic inflammatory disease with multi-system involvement. Typically occurs in women between 40 to 50 age. Women 40 to 50 age. Characteristic feature: the keratoconjunctivitis (SICA), dry eye. The primary Sjogren syndrome patient presents with SICA complex, a combination of cases with xerostomia, dryness of mouth. In secondary Sjogren, dry eye or dry mouth are associated with autoimmune disease, commonly rheumatoid arthritis. Then watering eye: it is characterized by outflow of tears from conjunctival sac. Condition may occur either due to excessive secretion or result from inadequate drainage or normal secreted tears. Primary causes: primary hyperlacrimation is a rare condition which occurs due to direct stimulation of lacrimal gland. Reflex hyperlacrimation: it results from stimulation of sensory branches of fifth nerve due to irritation of corneal conjunctiva. It may occur in multitude of conditions which include affection of lid, affection of conjunctiva, affection of cornea, affection of sclera, affection of uveal tissue, acute glaucoma, endophthalmitis, panophthalmitis. Effect of lid may due to stye, herdiolum internum, acute meibomitis. Conjunctiva affect due to conjunctivitis, which may be infective, allergic, toxic, irritative. Corneal aberration, corneal ulcer, etc. Central lacrimation: psychical lacrimation. Exact area concerned with the central lacrimation is still in not known. Cause of Vivifora: inadequate drainage of tears may cause physiological and anatomical causes. Physiological cause is lacrimal pump failure due to lower lid laxity or weakness of orbiculus muscle. Then mechanical obstruction is lacrimal passage may be lie at level of punctum, canaliculus, lacrimal sac, or nasal lacrimal duct. Punctal causes: eversion of lower punctum, punctal obstruction. Eversion of lower punctum, it is commonly seen in old age due to laxity of lids. Then it occurs due to prolonged use of drugs like hydroxyurea, pilocarpine, etc. Punctal obstruction, there may be congenital absence of puncta or cicatricial closure following injuries, burns or infection. Rarely a small foreign body may be occluded in that area. Cause in canaliculi. Canalicular obstruction may be congenital or acquired due to foreign body trauma, idiopathic fibrosis, etc. Cause in lacrimal sac. These include congenital mucous membrane folds, traumatic strictures, dacrocystitis, specific infection like tuberculosis, syphilis, dacrolithias tumors, etc. Causes in nasolacrimal. Congenital lesions include non-canalization, partial canalization, or imperforated membranous valves. Clinical evaluation of case of watering eye. Ocular examination with diffuse illumination using magnification should be carried out to rule out any cause of reflex hypersecretion located in lids, conjunctiva, cornea, sclera, anterior chamber tract, and so on. Regurgitation test. Steady pressure with index finger is applied on lacrimal sac area above the medial purple ligament. Reflex of mucopollen discharge indicates chronic dacrocystitis with obstruction on lower end of sac or nasolacrimal duct. Fluorescein dye disappearance. In this test, 2 drops of fluorescein dye are instilled in both the congenital sacs. Normally, no dye is seen in congenital sac. Prolonged retention of dye in congenital sac indicates inadequate drainage, which may be due to atonia of sac or mechanical obstruction. Lacrimal syringing. It is performed after topical anesthesia with 4% xylocaine. Normal saline is pushed into lacrimal sac from lower rectum with the help of syringe and lacrimal canal. Free passage saline through lacrimal into nose rules out any mechanical obstruction. Presence of partial obstruction, saline passes with concealed pressure on syringe. Presence of obstruction, no fluid passes into nose. Jones dye test. Jones primary test. Jones secondary test. Primary test is performed to differentiate between watering due to partial obstruction of lacrimal passage from that due to primary hypersection of tears. 2 drops of 2% fluorescein dye are instilled in the congenital sac and a cotton bud dipped in 1% xylocaine is placed in the inferior meatus. After dye stained cotton bud indicates adequate drainage through lacrimal passage and cause of watering is primary hypersecretion. While unstained cotton bud indicates either a partial obstruction or failure of lacrimal pump. To differentiate between these conditions, Jones 2 test. When primary test is negative, the cotton bud is again placed in the inferior meatus and lacrimal syringing is performed. Positive test suggests that dye was present in the sac but could not reach the nose due to partial obstruction. Dacrocystography. Normal dacrocystogram. It is valuable in patients with mechanical obstruction. It tells the exact site, nature, and extent of block. Radionuclide dacrocystography is a non-invasive technique to access the function efficient of lacrimal drainage. Then dacrocystitis. Dacrocystitis is the inflammation of lacrimal sac is not an uncommon condition. Congenital dacrocystitis. It is an inflammation of lacrimal sac occurring in a newborn infant and thus also known as dacrocystitis neonatorum. Etiology. It follows tests of secretion in the lacrimal sac and it is very common occurrence. As many as 30% of newborn infants are believed to have closure of nasolacrimal duct at birth. Membranous occlusion at its lower end near the valve of Hasner is the commonest cause. Other causes of congenital NLD block are presence of epithelial debris, membranous occlusion at its upper end near lacrimal sac, complete non-canalization, rarely bony occlusion. Common bacteria associated with congenital dacrocystitis are Staphylococcus, pneumococcus, streptococcus. Then lacrimal scintillography showing normal lacrimal extension on the right side. Normal lacrimal extension. Obstruction of the junction of lacrimal sac and nasolacrimal duct on the left side. Clinical features. Congenital dacrocystitis usually presents as mild grade chronic inflammation characterized by epiphora, usually developing after 7 days of birth. It is followed by copious mucopollen discharge from eyes. Regurgitation is usually positive, that is when pressure is applied over the lacrimal sac area. Purulent discharge regurgitates from the lower punctum. Then swelling on the sac area may appear eventually. These are the clinical features. Epiphora, regurgitation test. Purulent discharge is regurgitated. Then differential diagnosis. Ophthalmology neonatal congenital glaucoma. It is differentiated from other cause of watering in early childhood. Glaucoma, congenital glaucoma, ophthalmos, and it is cause of watering, also a cause of watering. Complication not treated in the time, it may complicate recurrent conjunctivitis, acute or chronic dacrocystitis, lacrimal abscess, and fistula formation. Treatment: massages over lacrimal sac area and topical antibiotics should be given. It constitutes the mainstay of NLD block. Massages increase the hydrostatic pressure in the sac and help to open up membrane circulation. It should be carried out at least 4 times a day, to be followed by instillation of antibiotic drops. This conservative treatment coupled with spontaneous recanalization cure obstruction in 90% of infants up to 6 to 9 months. Lacrimal syringing with normal saline and antibiotic solution. It should be added to conservative treatment if the condition is not cured up to the age of 3 months. Lacrimal irrigation helps to open up membrane circulation by exerting hydraulic pressure. Syringing may be carried out once a week or once in 2 weeks. Probing of NLD with Bowman probe, it should be performed in cases in condition not cured at age of 6 months. Some surgeons prefer to wait till age 9 to 12 months and perform under general anesthesia. While performing probing, care must be taken not to injure the canaliculus. In most instances, a single probing will relieve the obstruction. Case of failure, it may be repeated after an interval of 3 to 4 weeks. Balloon catheter dilation with help of probe carrying inflated balloon. Inflated balloon may be carried out in children where repeated probing is failure. Intubation with silicone tube may be performed if repeated probings and balloon catheter dilation are failure. Dacrocystorhinostomy (DCR) operation, when the child is brought very late or repeatedly probing, balloon catheter dilation and intubation are a failure, then conservative treatment by massaging topical antibiotics. Intermittent lacrimal syringing should be continued till the age of 4. After this, DCR operation should be done. Adult dacrocystis, chronic dacrocystis, it is acute or chronic. Chronic is more common than acute. Etiologies of chronic dacrocystis is multifactorial. Well established fact is a vicious cycle of stages and mild infection of long duration. Etiology factors can be grouped as age 40 to 60 years, more common in females, race, Negroes than whites, hereditary, socio-economic status, poor personalizing. Factor responsible for stress of tears in lacrimal sac duct. Anatomical factors which retard drainage of tears include comparatively narrow bony canal, partial canalization, membranous NLD, excessive membrane fold in NLD. Foreign bodies in sac may block opening of NLD. Excessive lacrimation, mild grade inflammation of lacrimal sac due to recurrent conjunctivitis may block NLD by epithelial debris and mucous plugs. Then obstruction of lower end of NLD by nasal diseases such as polyps, hypertrophy in inferior concha, marked degree of deviate nasal tumors and atrophic rhinitis causing stenosis may also cause stagnation of tears in lacrimal sac. Source of infection: lacrimal sac may get infected from conjunctiva, nasal cavity, or paranasal sinus. Causative organisms: staphylococci, pneumococci, streptococci, pseudomonas, pyocynia. Rarely, chronic granulomatous infection like TB, syphilis, leprosy, rhinosporidium may also cause dacrocystis. Clinical feature of chronic dacrocystis may be divided into 4 stages. Stage of chronic catarrhal dacrocystis. It is characterized by mild inflammation of lacrimal sac associated with blockage of NLD. Watering eye is the only symptom in this stage, and sometimes mild redness in the inner canthus. Then on syringing lacrimal sac, either a clear fluid or few fibrous mucoid flakes regurgitate. Dacrocystography reveals block in NLD, a normal size lacrimal duct with healthy mucosa. Stage of lacrimal mucosal, it follows chronic stagnation causing distension of lacrimal sac. Characteristic features include constant epiphora associated with swelling just below the inner canthus. Mucosil, is lacrimal mucosil. Its characteristic feature: constant epiphora associated with swelling, epiphora plus swelling just below the inner canthus. Regurgitation: milky or gelatinous mucoid fluid regurgitates from lower punctum on pressing the swelling. Dacrocystography at this stage reveals a distended sac, blockage somewhere in the nasolacrimal duct. Insistent mucosal, sometimes due to continued chronic infection, opening of the both canonically into sac are blocked, and large fluctuant swelling is seen in the inner canthus with a negative regurgitation. This is called insistent mucosal. Stage of chronic suppurative DC. Due to pyogenic infection, mucoid discharge becomes purulent, converting into mucocele into pyocele. Chronic infections. Condition is carried by epiphora associated with recurrent conjunctivitis, swelling at inner canthus, mild erythema over skin, overlying skin. On reagent, frank purulent discharge flows over the lower tongue. If openings of canal get blocked at the stage, so-called encysted pyocele. Stage of chronic fibrotic sac. Low grade repeated infection for a prolonged period ultimately result in small fibrotic sac due to thickening of mucosa. Dacrocystography at this stage reveals a very small sac with irregular folds in mucosa. Complication: chronic intractable conjunctivitis, acute or chronic dacrocystitis, ectropion of lower lid, chance of corneal ulceration, or thus those as simple corneal abrasion may become infected. High risk of developing endophthalmitis is always there if an intraocular surgery is performed in presence of dacrocystitis. Treatment: conservative balloon catheter dilation, conservative probing and lacrimal syringing may be used in recent cases. Long-standing or most always associated with blockage of NLD. Balloon catheter success rate reported in adults about 50%. Dacrocystorhinostomy is usually not done in children, but in adults it is done. It should be an operation of choice as it re-establishes the lacrimal drainage. However, before performing surgery, the infections, especially pyocele, should be controlled by topical antibiotics. Dacrocystectomy (DCT), acute dacrocystitis, stage of lacrimal abscess. Acute dacrocystitis, stage of external lacrimal fistula. It's in the feature acute dacrocystitis. Dacrocystectomy, it should be performed only when DCR is contraindicated. Indication of DCT include 2 young children, 2 old patients, markedly shrunken fibrous sac, tuberculosis, syphilis, leprosy, and disorders, tumors of sac, gross nasal disease, atrophic rhinitis, unskilled surgeon, because it is said that a good DCT is always better than a badly done DCR. Conjunctivodacrocystorhinostomy (CDCR), it is performed in the presence of blocked canaliculi. Acute DCR, it is not common as that of chronic. Etiology: an acute extracerebral chronic dacrocystitis, acute peridacrocystitis due to indirect involvement of neighboring infected structures such as paranasal sinus, bones, dental abscess, causative organism, streptococcus hemolyticus, pneumococcus staphylococci. Clinical features: stage of cellulitis, stage of lacrimal abscess, then stage of fistula formation, stage of fistula. Stage of cellulitis, it is carried by painful swelling in the region of lacrimal sac associated with epiphora. Constitutional symptoms such as fever and malaise. Swelling is red, hot, firm, and tender. Redness and edema also spread to the lids and cheek. When treated, resolution may occur at this stage. However, if untreated, self-resolution is rare. Stage of lacrimal abscess, continued inflammation causes occlusion of canaliculi due to edema. The sac is filled with pus distance and its anterior wall ruptures, forming a pericystic swelling. In this way, large fluctuant swelling the lacrimal abscess is formed. It usually points below to the outer side of the sac, owing to gravitational force, presence of medial palpable ligament in the upper part. Stage of fistula formation: when the lacrimal abscess is left unattended, it discharges spontaneously and leaving an external fistula below the medial palpable ligament. Rarely the abscess may open up into nasal cavity, forming internal fistula. Complications: acute conjunctivitis, corneal abrasion, lid abscess, osteomyelitis or lacrimal bone, orbital cellulitis, facial cellulitis. Rarely cavernous sinus thrombus. Very rarely generalized septicemia may also develop. Treatment: during cellulitis, so systemic topical antibiotic to control infection, systemic anti-inflammatory analgesic drug, hot fermentation to relieve pain and swelling. During the stage of lacrimal abscess, in addition to above treatment, when pus starts binding on skin, drained pus should be drained with a small incision. Then pus should be gently squeezed out and the dressing done. Betadine soaked roll gauze. Treatment of external lacrimal fistula offer after controlling the acute infection. The systemic antibiotic fistulectomy along with DCT or DCR should be done. Surgical technique: conventional external approach DCR and intranasal approach endocanalicular laser, and conventional external approach DCR. First is anesthesia given, then skin incision, either a curved or curved incision along the anterior lacrimal crest, or a straight incision 8 mm medial to medial canthus made. Anesthesia: curved or straight incision. B. Exposure of bony lacrimal fossa. Bony lacrimal fossa is exposed. Medial palpebral ligament is exposed, and cut scissor to expose the anterolacrimal crest. Then dissection, preparation of bony osteum, exposure of nasal mucosa, preparation of bony osteum preparation, and exposure of nasal mucosa exposure. Dissection of lacrimal sac. Periosteum is separated from anterolacrimal crest along with the lacrimal sac reflected laterally with blunt dissection, exposing lacrimal fossa. Exposure of nasal mucosa. 15 mm and 10 mm bony osteum is made by removing the anterior lacrimal crest and the bones forming the lacrimal fossa, exposing thick pinkish white nasal mucosa. Preparation of flaps of sac. A probe is introduced into sac through and then through lower canal, sac is incised vertically. Then to prepare anterior and posterior flap, this incision converted into H-shaped. Fashioning of nasal mucous flaps is also done by vertical incision converted into H-shape. Suturing of flaps. Posterior flap of the nasal mucous is sutured with posterior flap of the sac using 6-0 vicryl or chromatic catgut switches. Closer. MPL is sutured with periosteum orbital muscle, sutured with 6-0 vicryl. Skin is closed with 6-0 silk switches. Then endonasal DCR. Surgeries of endonasal DCR. Endoscopic identification of sac area in the middle meatus. Sac area ID identification. We see opening created in the middle meatus. Opening in middle meatus. Then D. Stenting of rhinostomy opening with fine silica to stenting. Endonasal DCR. Preparation of an anesthesia. Conjunctival sac is anesthetic. Then 3 ml of lignocaine with 1/2 lakh adrenaline is injected into middle parts of upper and lower eyelids. Identification of sac area. 20 gauge light pipe is inserted by the upper canal into sac. With the help of endoscope, the sac area which is transluminated by light pipe is identified. Creation of opening in the nasal mucus, bones forming the lacrimal fossa and posterior medial wall of sac can be accomplished by two techniques: by cutting the tissue with appropriate instruments or ablating the holmium YAG laser. Stenting of rhinostomy opening. Outflow centered with silicone tubes passed via inferior and superior canali into rhinostomy. Post-operative care and removal of elastic lacrimal stents. After 20 hours of operation, nasal packs are removed and patient is advised to use decongestant, antibiotic and steroid nasal drops for 3 to 4 weeks. Advantages and disadvantages of EDCR. Service external DCR. Endonasal DCR, no external cutaneous scar. Related blood less surgery, blood more bleeding, better visualization, less chance of injury, potential injury to adjacent medial canthus, less time consuming, more operating time, no post-operative morbidity, significant post-operative morbidity. Disadvantages: less success rate, more success rate, skilled ophthalmologist, easily performed by ophthalmologist, expensive equipment, cheap, requires reasonable access to middle meatus, not require endoscopy. Endocanalicular laser DC. In this laser probes pass through a canaliculus into upper middle, and opening is created by ablating the posterior wall and bone forming lacrimal fossa and adjacent nasal mucosa. It is performed by holmium YAG KTP laser. Success rate is only 70%. Surgical technique of dacrocystectomy. 1 to 4 removal of lacrimal sac. After exposing the sac, it is separated from surrounding structures by blunt dissection, followed by cutting its connection from lacrimal canaliculi. It is then held with artery forceps and twisted 3 to 4 times to tear it away from the nasal lacrimal duct. Curettage done with the help of lacrimal crit to remove infected parts. Closer. Swelling of lacrimal. Acute dacroadenitis. Etiology: it may develop a primary inflammation of gland or secondary to some local or systemic infection. Dacroadenitis secondary to local infection occurs in trauma, erysipelas, face conjunctivitis, and orbital cellulitis. Dacroadenitis secondary to systemic infection associated with mumps, influenza, infection, mononucleosis, measles. Clinical feature: acute inflammation of palpable part is characterized by painful swelling in the lateral part of upper lid. The lid becomes red and swollen with a typical S-shaped curve of its margin. Acute orbital dacroadenitis producing some painful process in which eyeball moves down and in. A fistula in the upper and lateral quadrant of upper lid may develop as complication of separated dacroadenitis. Treatment: it consists of course of appropriate systemic antibiotic, analgesic, and anti-inflammatory drugs along with heart fomentation. When pus is formed, incision drainage should be carried out. Chronic dacroadenitis characterized by a patient with bilateral dacroadenitis. It is characterized by engorgement, simple hypertrophy of gland. Sequel to acute inflammation, etiology, and association with chronic inflammation conjunctiva due to systemic diseases, tuberculosis, syphilis, and sarcoidosis. Clinical feature: painless swelling in upper and outer part of lid. Eyeball may be displayed down in. Diplopia may occur in up and out gaze. On palpation, firm lobulated mobile mass felt under upper and outer rim of orbit. Differential diagnosis from other cause of lacrimal gland swelling, best made from after fine needle aspiration biopsy or incision biopsy. Mikulicz syndrome: down and displacement left eyeball in patient with benign mixed tumor. B. CT scan showing well-defined mass of supertemporal quadrant. Then well circumference benign mixed tumor removed by lateral orbitomy. Mikulicz syndrome characterized by bilateral symmetrical enlargement of lacrimal and salivary glands associated with a variety of systemic diseases. These include leukemia, lymphosarcoma, benign lymphoid lipedysplasia, Hodgkin disease, sarcoidosis, and tuberculosis. Dacryops: it is a spastic swelling which occurs due to detention of lacrimal secretion following blockage of lacrimal ducts. Tumor of lacrimal gland: epithelial tumor of lacrimal gland. These account for 50% of tumor swelling of lacrimal gland and include benign epithelial tumors. These include benign mixed tumor, which accounts for 50% of epithelial tumors and 25% of all tumors of lacrimal gland. Malignant epithelial tumor: these also constitute 25% of all cases, 50% of epithelial tumors. Malignant mixed tumor, adenoid cystic carcinoma, mucoepidermoid carcinoma. Non-epithelial tumors of lacrimal gland constitute approximately 50% of all cases. Lymphoproliferative tumors and inflammatory condition: idiopathic orbital inflammatory Mikulicz syndrome. Epithelial tumors of lacrimal gland: pleomorphic adenoma. Presents a slowly progressive painless swelling in the upper outer corner of orbit, displacing the eyeball downwards and inwards. It is locally invasive and may infiltrate into its own pseudocapsule. It involves the adjacent periosteum. Histology: it is characterized by presence of pleomorphic myxomatous tissue, just like benign mixture of salivary gland. Treatment: recurrence are very common. Complete surgical removal. Lacrimal gland carcinoma: malignancy occurring 4th to 5th decade of life. The main histology type of adenoid cystic carcinoma, pleomorphic adenocarcinoma, mucoepidermal carcinoma, squamous cell carcinoma. Clinical feature: lacrimal gland malignancy present as painful mass of short duration in superior-temporal quadrant of orbit, causing infranasal dystropia. CT scan often shows an infiltrated tumor molding in the globe. Treatment includes complete macroscopic excision and high-dose radiotherapy to the orbit.